Hi everyone, and thank you for joining us for the Antenatal Shared Care Obstetrics update as part of the Hazelhurst CPD series. My name is Elise King and I'm the project officer who looks after the Antenatal Shared Care program for the St George and Sutherland hospitals through Central and Eastern Sydney PHN. Also with us tonight is Lauren Thomas, CPD program officer at the PHN. I would like to start by acknowledging the traditional custodians and sovereign people of the land across which we work. I recognise their continuing connection to land, water and community and pay respect to elders past, present and emerging. I also extend that respect to Aboriginal and Torres Strait Islander peoples joining us tonight. So a bit of housekeeping before we get started. At the end of the webinar, the evaluation survey will be available from the chat box and also will be sent to your email, and we really appreciate your feedback. Please complete this to allow us to issue certificates of attendance. Tonight's event has been RACGP accredited for 1.5 hours of educational activity and 1 hour of reviewing performance activity. To qualify for both, you'll be required to attend today's session in its entirety and complete the post activity, which will be sent out after the webinar. We'll submit your activity hours that you've completed on your behalf. Please submit your questions to the Q&A box and they will be answered during the panel discussion at the end of the session. I'd also like to draw your attention to the upcoming events that will be up on the screen in a moment. So we've got cancer survivorship on Wednesday, the 6th of September at Tradies Gymea. Antenatal shared care update on Wednesday, the 20th of September at Tradies Gymea. And cultural awareness training on 18th of October at Tradies Caringbah. Registrations for these events are available on the Central and Eastern Sydney PHN website. And I'll just share a few program updates with you. Hyperemesis gravidarum management by a hospital in the home is an acute service provided to patients residing within the St George area for care in their homes as a substitute for in-hospital care. They're open 7 days a week from 7:30 a.m. to 9:30 p.m, including public holidays. And more information will be sent out via email after the webinar. Get Healthy in Pregnancy is a service which provides free phone coaching to support pregnant women. Dr Hester Wilson will be providing some more information in her presentation about this. And I would now like to introduce our first speaker for tonight, Edwina Chan, who is a physiotherapist specialising in pelvic health issues and musculoskeletal problems. She's been a physio for 22 years and has worked in the field of women's health since 2009. Edwina works with 2 obstetricians at St George Private and is also at St George Public part-time as the Senior Women's Health Physiotherapist. Edwina will be presenting on pelvic floor in pregnancy and postnatal period. Thanks, Edwina.
So this is a topic that's really close to my heart because it's an area that I treat a lot of women postpartum when they have birth injuries and pelvic floor disorders postpartum. So it'd be really great if we could address some of these issues during pregnancy. Okay. So the main discussion points that I'm going to be talking about today is first of all, I'm going to look at antenatal and postnatal risk factors for pelvic floor disorders, why pelvic health physiotherapy during pregnancy is helpful, some practical tips on how you can get patients to see if they can activate their pelvic floor, what we look for in the 6-week postnatal check as physios. I'm going to talk about the perinatal care clinic. OASI is for obstetric anal sphincter injuries at St George Public. And I'm going to talk about then the pelvic floor disorders in the postpartum woman and briefly talk about exercise in the pregnant and postpartum woman. So first of all, the risk factors for pelvic floor dysfunction in the antenatal period are a previous history of bladder and bowel problems, including bedwetting, age of over 35, BMI of more than 30, chronic constipation, including chronic straining more than 25% of the time, and use of laxatives, and multiparity. So if they have any previous history of bladder or bowel issues and pelvic pain, we would recommend that they get referred to us during the antenatal period. And also, I just wanted to bring your attention to the clinical care standards, which were produced with Associate Professor Emmanuel Karantanis and a group of other people nationally, so that there is a standard to help for women to look at, consumer handout to reduce the risk of perineal tears, and that's in a number of languages. And there is also another handout to help women who've experienced a 3rd or 4th degree tear. And so if you just Google clinical care standards and 3rd and 4th degree tear, it will come up. In terms of postnatal risk factors, the main risk factors are having a baby of 4 kilos or more, a prolonged second stage of more than an hour, forceps or vacuum, particularly forceps more than vacuum, and perineal trauma of 2nd degree tear onwards. One study by Karantanis et al. Showed in a retrospective review that women with 2nd degree tears are just as likely to have flatal incontinence as women with 3rd degree tears, and women with a 3rd degree tear are also more likely to have a levator avulsion, which increases the risk of prolapse. So basically, the take-home message is obstructed labour, which can lead to prolonged second stage or need for instrumental delivery, particularly forceps, substantially increases the risk of both 3rd degree tears and levator avulsion. So why would we recommend having pelvic health physio during pregnancy? I mean, a lot of you know that up to 80% of women can get pelvic girdle pain or back pain, so they're often referred for that. But also, if women are symptomatic in terms of urinary incontinence, or they have a history of dyspareunia or chronic pelvic pain, or they don't know how to use their pelvic floor muscles correctly, then we would recommend that they get seen during pregnancy. They can be seen anytime. In terms of an internal vaginal exam for pelvic floor review, we usually recommend that from 20 weeks after their 20-week scan and at 36 weeks. However, if the woman is at high risk and cannot have a vaginal exam, or they don't want one during pregnancy, there are other ways we can assess for pelvic floor muscle function. We just can't test strength. So the ways we would do that is I can do a transabdominal ultrasound to look at their bladder base to approximate, contract and relax of their pelvic floor. Or you can do a transperineal ultrasound, which is on their perineum, or they can do a visual assessment of the vagina and perineum. In terms of education on pelvic floor muscle training, it includes appropriate relaxation of pelvic floor muscles, not just contraction, how to bear down effectively, so to make sure that they're not co-contracting and reducing their levator hiatus when they're trying to bear down. And perineal massage from 36 weeks does have evidence to prevent 3rd and 4th degree tears. So I'm just going to go briefly through a case study to help bring these messages to light. This is an example of a patient, could be any of my patients really, that has presented during pregnancy because she has some stress incontinence. Stress incontinence, urinary incontinence during pregnancy can range between 30 to 65% during pregnancy at any time, and 50% of them will get better after delivery without doing anything. However, that's 50% that don't. So this patient, it's her first pregnancy, she's 25 weeks, she's started to get some stress incontinence with coughing only after the flu. She has had a previous history of dyspareunia and difficulty inserting tampons, and that's been long-standing. What she's most concerned about is her mode of delivery, more than the stress incontinence, but she's adamant that she doesn't want a cesarean unless absolutely necessary. And on examination, she had high tone of her pelvic floor muscles at rest and difficulty contracting and relaxing her pelvic floor muscles. So my analogy for these patients are often they are, if you think of an elevator of like 0 is where you should be at baseline. The basement is when you bear down to do a poo. And then say level 10 is when you are able to contract your pelvic floor at its maximal contraction. For this woman, she's hovering around a 3 to 4 on the elevator at that floor all the time. So she's always tensing it slightly, and she's unaware of how to increase contract her pelvic floor muscles, but she also doesn't know how to relax them. And that's probably why she's getting stress incontinence with coughing. So what she needed to learn to do was actually relax her pelvic floor and contract it. When she contracts it with coughing, it actually helped. The other thing that she needed to learn was how to contract her pelvic floor and relax it fully and allow it to relax when she's bearing down. We would have also discussed things like, if she does need forceps or vacuum, that an episiotomy is actually protective for a 3rd or 4th degree tear, as a forceps delivery without an episiotomy increases the risk of a 3rd degree tear by 17 times. And for vacuum without episiotomy, it increases the risk of 3rd degree tear by 6 times. So it's helpful for these patients to know that we're not suggesting that everyone should have an episiotomy, but if they end up having an instrumental delivery, that can be protective to prevent against OAC. Obstetric anal sphincter injury. So why do pelvic floor exercises? There's actually level 1 evidence that pelvic floor muscle training can help prevent urinary incontinence. So that's why we actually recommend, if women don't know how to do their pelvic floor exercises, even if they are not incontinent during pregnancy, we would recommend that they get reviewed if possible. We know that from a Cochrane review that pelvic floor muscle training should be the first line of intervention for urinary incontinence in women. And for stress incontinence, there can be a significant improvement or cure rate of up to 70% in women with mild stress incontinence and up to 50% in women with moderate stress incontinence. There was also a big randomized control trial which St George was involved in, the POPPY trial, which showed that there can be significant improvement in symptoms for mild to moderate prolapse with individualized pelvic floor muscle training. As I said, the prevalence of urinary incontinence anytime during pregnancy can be between kind of 30 to 65%. And it's a well-known quote that 1 in 3 women after having a baby may leak. But interestingly, only 1/3 of women will tell their GPs about their urinary incontinence. And lastly, I wanted to say that patients will often ask, I'm already doing Pilates, isn't that enough? But there was a study which showed that pelvic floor muscle training is not effective at preventing urinary incontinence when it's taught in a general antenatal fitness class. In terms of teaching pelvic floor muscle exercises, I'm not expecting you to be experts in this, but if patients ask you how to do it and they can't afford a physio or they don't want to see one, the best idea is to give them verbal or visual cues which are physiological. So for example, trying to stop the flow of urine, trying to hold on to wind, imagine drawing up a tampon inside, or imagine a pin is approaching your anus and you want to pull away from it. In terms of practical tips, like explaining what a pelvic floor muscle contraction should involve. So they should be able to, as you can see from this picture, still maintain breathing. They shouldn't be using their accessory muscles. So that's your gluteals, your adductors, and your upper abdominals. Often they cheat doing that. It's very easy to hold your breath. I really try and make it easy to remember and achievable for patients. So focusing on strength training. I don't tell them to do it 3 times a day. I just say if you can do even 6 to 8 reps, 5 to 6 second hold, make sure you relax fully after each contraction and aim for 2 to 3 sets. That's enough. If they're weak or they're unable to do a pelvic floor muscle contraction, then I would refer on, or if they have a history of pain, I'd refer on. It's important to note that 4 out of 10 women do their pelvic floor muscle exercises incorrectly if they're just giving it a pamphlet. And in symptomatic patients, up to 40% bear down, 40% do contract, and 20% don't do anything when they're just given a pamphlet. In terms of the 6-week postnatal check, we do think that, I mean, not everyone has to see a physio, but I think that when you're examining their perineum, a digital vaginal exam and a visual assessment, at least a visual assessment of their pelvic floor muscles and their perineum is very helpful. So I would be looking for the anal wink and the indrawing of their vagina, so you're getting a squeeze and lift, and as well a relaxation. I think it's helpful if you do screen for pelvic floor disorders postpartum, and also it's important to screen for whether they've had birth trauma, and that's physical and mental. Just asking open-ended questions about their birth experience can really open up a whole series of questions, perhaps not in 15 minutes that you can cover, but just it's interesting the number of women that report birth trauma, and I think this was reported recently in an ABC article, which was a study, I think, in Griffith. Anyway, it was recent. And finally, while I said 1 in 3 women may leak after having a baby, it's also important to note that 1 in 10 women may also experience anal incontinence, and that's not asked or discussed. Bringing on to that, in terms of the perineal tear or OASI clinic, obstetric anal sphincter injury clinic, this is a public service at St George Hospital. We recommend that anyone who's had an OASI is allowed to be referred there, and that's not just patients residing within the St George or Sutherland area. So we recommend that, patients that deliver at St George or Sutherland Public are automatically referred to the perineal tear clinic, and they are seen by a physio at hospital, and then they're seen at 6 weeks. If your patient delivered privately, they are also welcome to be referred to the perineal tear clinic, and the first time we would see them is at the 6-week mark. If they're concerned, or you're concerned before that, they're also welcome to call physio. I have the number at the end, and speak to the women's health physio, because we can always call them beforehand, before that 6 weeks, if they're worried. So at 6 weeks, they are reviewed by the physio, which is lovely Rachel Wilshire standing there. And however, it is a multidisciplinary team, and so they are able to be seen by the urogynecologist and registrars if needed at 6 weeks. So we take a birth history, we do the St Mark's score for their anorectal function, so we have a baseline. When we assess their bladder and bowel function, we also do a digital vaginal and rectal exam with informed consent and review for pelvic pain and perineal pain. We assess their ability to contract and relax both their sphincter muscles and their pelvic floor muscles vaginally. And it's a lot of education as well as debriefing. They are also able to have a medical debrief if required. And so we determine that based on what we find. The other thing I would say is that sometimes women complain of pain in their perineum. Sometimes they can actually feel a stitch, and for the repair of the sphincter, it should be done in theatre, but also you should be aware that the PDS stitches for the sphincter repair, it takes up to 4 months to dissolve. So it may be uncomfortable for some time. And even if they are already seeing a physio privately, we would recommend that they come to the OASI clinic. They can continue to see their physio privately, but it's because once they're in the clinic, they get the multidisciplinary care, and they are also automatically referred for the anorectal physiology tests at 6 months, and then they will have an appointment with the urogynecologist and his team at 6 months as well to discuss the results of that. So I just wanted to bring to light another case study. This was a patient of mine who had a 3A tear, so that's less than 50% of the external anal sphincter. She actually came to me privately at 4 weeks postpartum because she had perineal pain. I asked that she got a GP referral to the OASI clinic at 6 weeks so that she would be reviewed there as well. She actually didn't have any anorectal symptoms, so she didn't have any anal incontinence or fecal urgency, but she had her main issues initially with the perineal pain and the coccyx pain. When she had her anorectal physiology tests at 6 months, they were normal, but she had ongoing dyspareunia. She was unable to have sex for a very long time, and she had ongoing back pain and coccyx pain. There were also compounding contextual factors in terms of she had some relationship issues with her husband, and she wasn't from Australia. She had no family. She was quite socially isolated. And so what we did with this woman was that she ended up, she did express that she felt that she'd had some birth trauma. So she ended up seeing a psychologist for herself, and they also, her husband also saw a marriage counsellor. I'm pleased to say that they got through that first year, and she's no longer getting dyspareunia. She does still have some ongoing back pain and coccyx pain. And now that she's 14 months postpartum, I've recommended that she sees a colleague of mine for her back pain. It was so that I could, for myself, separate out for her coccyx pain, pelvic pain versus her musculoskeletal issues, because she also has chronic neck pain. And I think a lot of that is about other contextual factors such as ongoing poor sleep, stress, and not exercising. And sometimes having another approach from another person can be helpful. So moving on to common pelvic floor disorders postpartum. As I've already mentioned, stress incontinence is very common. Prolapse is often a concern for patients. They also worry a lot about their diastasis these days, but I'm not going to talk about that today. There may be new onset of pelvic pain, or persistent dyspareunia, or perineal pain. Some patients can experience voiding dysfunction. It's actually quite common. Up to 50% of women may get reduced sensation to void initially postpartum, but it should usually resolve by 6 to 8 weeks. And if that hasn't, we would say refer on. And some women have a history of bedwetting or a history of urgency, and sometimes that gets worse postpartum with overactive bladder syndrome. And also, as I've mentioned, there can be anorectal disorders. In case I forget, I also wanted to say that if your patient has not experienced a 3rd degree tear that we know of, but is experiencing anal incontinence and reside in the St George or Sutherland area, they are also welcome to be referred to the perineal tear clinic. So in terms of urinary incontinence, the most common presentation postpartum is stress incontinence, where they leak with pressure on the bladder. So it may be lifting their baby, or coughing, sneezing, lifting, walking. But they may also have mixed incontinence or overactive bladder syndrome. So increased frequency, urgency, urgent incontinence in the absence of a urinary tract infection. If they are very early postpartum, I would also, if you can, check their post-void residual and whether they're having reduced sensation to void, to ensure they're not experiencing overflow incontinence. We should pick that up in hospital, but just in case. And the other thing we suggest there, if they do have reduced sensation to void, is that they wee every 2 to 3 hours. So they time their voiding initially, regardless of urge to void. And it can be helpful to do a bladder diary as well, to see how much they're drinking and actually weeing, and the time between wees. So pelvic organ prolapse. This is often a big fear for postpartum women. I would say that it's important to note that prolapse needs to be symptomatic as well as showing clinical signs of prolapse, as per the most recent definition by IUGA. Symptoms do not correlate well with stage of prolapse. So pelvic organ prolapse is a symptomatic descent of one or more of the anterior vaginal wall, the posterior vaginal wall, or the cervix. And I mean, you're unlikely to see an enteroceal. Oh, it's not that good. Postpartum. Like I said, the signs must be correlated with the relevant symptoms. It's important to note that the vaginal walls are not made of concrete. So there was a study which actually showed that 50% of women at 25 years of age can have a stage 1 anterior wall movement on bearing down, but this doesn't mean they have a prolapse. But I would say, if your patients are worried or symptomatic, always refer on, because worry and fear can play a big part in pelvic organ prolapse. And the other thing I would say is that at 6 to 8 weeks, often women do feel some heaviness, and the best correlation to true prolapse is actually seeing a bulge. more than the heaviness or dragging, because women can have discomfort or some dragging feeling, and sometimes that can also be vaginal atrophy because they're breastfeeding. So yeah, it's important to have a look and refer on if you're concerned. In terms of pelvic pain, we tell patients, particularly after OAC, not to have sex for 6 weeks until they review with us. So it's when you see them at the 6-week mark, they won't be able to tell you necessarily whether they've got pain with sex. But if they've had a previous history of pain with sex, I think that's a good idea to screen for whether they wanted to see someone. Or if they tell you that they're experiencing pain with intercourse postpartum, please refer them to a women's health physio, because it's not normal. It doesn't just get better with a glass of wine or some lubricant. I think it's really 1 in 5 women experience pain with intercourse. 1 in 5 women have pelvic pain. So it's really an area which we need to address adequately. Women who've had 3rd-degree tear have an increased risk of dyspareunia to up to 6 months postpartum, but at 12 months, the prevalence is equivalent to those without having an OAC. Some women may have new onset of dyspareunia, or it may be due to vaginal atrophy from breastfeeding. It may be because of perineal pain or discomfort. Sometimes they think that it's the stitches, but it's often the sensitivity of the scar rather than true tightness. Or they may have a worsening of their previous pelvic pain, which began before they ever had a child. In terms of bowel issues, I would say that, you guys must treat chronic constipation all the time, but if they're not getting better, please refer them. Sometimes it is actually obstructed defecation and they're not actually opening their bowels correctly. It's not just about stool type, fibre, laxatives and water. In terms of anorectal symptoms from OAC, as I said, the most common presentation is fecal urgency, and that's because when the external anal sphincter is involved, so a 303B tear, you're more likely to experience fecal urgency. Whereas for fecal incontinence, it's the internal anal sphincter which provides 70 to 85% of the closing pressure for the anus, and so that if it's a 3C or 4th tear, they may have fecal incontinence. Having said that, 2/3 of women that have had an OAC do not experience any anorectal symptoms after having a baby, until the main problem when they may experience issues is actually postmenopause. So usually in their 50s or 60s is when they may start to experience some more fecal incontinence. The most common anal incontinence postpartum is flatal incontinence. And as I said, that can happen with 2nd-degree tears as well as 3rd-degree tears. There is a possibility that some of those 2nd-degree tears were missed thirds. And that's why we say if they're experiencing symptoms, anorectal symptoms, such as anal incontinence, you're welcome to refer them to the perineal tear clinic. And lastly, hemorrhoids or fissures can be very, very bothersome postpartum as well. So that's worth referring to if they're not getting better, or to a colorectal surgeon. Lastly, I just wanted to touch on exercise and the pregnant woman. While this picture may seem controversial or confronting, it's important to note that the most recent 2022 guidelines suggest that exercise includes weight training, strength training for 2 times a week for pregnant women. It is the same number of minutes recommended in the guidelines for pregnant women as non-pregnant women. So that's 150 to 300 minutes of moderate exercise. 150 to 300 minutes of moderate exercise, or 75 to 150 minutes of more high intensity exercise. The main issue is that they don't get too hot, and also you wouldn't want to drop any weights on your pregnant belly. But if you've been lifting beforehand, there is no reason that you cannot keep lifting. And actually, there's also evidence that you can begin new exercise that you haven't done. We know that exercise prevents pelvic girdle pain and back pain during pregnancy. It also reduces the risk of gestational diabetes and the risk of preeclampsia. But as in the non-pregnant population, Australians are not getting enough exercise. So we certainly shouldn't be discouraging them from exercising. Exercise in the postpartum woman. So the thing is that women there is a whole gamut of women in terms of what they want to return to, hence my 2 pictures. Some women just want to be able to walk the Esplanade at Cronulla holding their baby in a baby carrier. And this is actually a common fear that I hear. Am I allowed to carry my baby in a baby carrier? Yes. I mean, of course, if they're symptomatic, we would look at that, but we really want women to be able to bond with their children, with their babies. We don't want to be scaring them. The other thing too is that, you know, your obstetrician or your GP says you're welcome to go back to your usual activity at 6 weeks postpartum, but we don't always know what that regular activity is. And that's why some women actually want to go back to an Olympic length triathlon. I had a patient that did 2 within 6 months postpartum, or a half marathon. And we would recommend that before returning to your usual activities of such high intensity sport, such as lifting or running, that they do get checked with a women's health physiotherapist. It varies for everyone. I would say that, for example, I had a patient who at 3 months postpartum was sick of doing the postnatal exercise class that she was doing. Luckily, her trainer referred her, and she wanted to get back to CrossFit. And when I examined her, if she'd had a normal vaginal delivery, she looked like she'd never had a baby. She actually had very high tone, but there was absolutely no reason. She had no prolapse. She had no symptoms. There was no reason she couldn't get back to her heavy-duty CrossFit if she wanted to. Women may actually first experience stress incontinence when they go back to exercise. Perhaps with everyday activity they didn't, but once they start doing one of those yummy mummy classes, they may experience some symptoms of heaviness or dragging or bulge. And we really do say, or pain, and we say, you know, refer them on. We can often help in terms of increasing their confidence and also looking at what's realistic for them. I really try not to say, no, you can never do that again, because that can be very disheartening and upsetting. And that's where I'm going to with this case study. So this patient presented to me actually in the public hospital. She was actually, we rang her at 2 weeks postpartum because she had some mild voiding symptoms in terms of reduced sensation to void. She was G2P2. She'd had an elective cesarean the second time. And that is because after her first delivery with forceps, she had a stage 1 cystocele diagnosed, so a mild anterior wall prolapse. And she also had an occulta wasi, which was found, a 3A tear, after she'd had a 3D, 4D ultrasound with Professor Peter Dietz, urogynecologist. The reason she went there was because she was highly distressed after her first delivery, and she'd seen a previous women's health physio who told her to stop her high impact exercise, which was lifting, and that she shouldn't run, and that she should wear a ring pessary, particularly when she's exercising, for her stage 1 cystocele. So I'd initially said to the patient, are you happy, you know, go back to your private physio. And it was at that 2 weeks, she said, can I just ask you, I really want to ask you about return to exercise. I said, yeah, that's fine. So that's why I saw her 6 weeks post-cesarean. So I only saw her after the second baby. She actually had, this was very important, she had a long history of pre-existing mental health issues, to the point where after the second delivery, the perinatal mental health team suggested inpatient admission, but she was very resistant to that and didn't want to go. She tried, but she turned around and went back home. She couldn't do it. So she was being managed by the perinatal mental health team, and I was managing her prolapse symptoms. She was very worried about her prolapse worsening, and her goal was to get back to exercise, particularly lifting and pole dancing, because that helped her mental health. And she wanted to bond with this baby because she really worried about bonding with this baby. She didn't bond with her first because she was too fearful to carry her first because of this mild prolapse, and because she was too fearful to carry her first baby in the carrier as well. So what did I do? I told her to stop using the pessary. And so after the first consult, she told me she threw it in the bin, and that actually made her feel better. because, and the only way we could do it was suck it and see, but her using that ring pessary for a stage 1 cystocele just made her feel more broken. It wasn't helping anything. We gradually, over a series of months, got her back to exercising, including doing lifting some weights and strength training, body weight training. And I have the benefit of that this is in the public hospital, so I'm able to see that she also mentioned to her perinatal mental health team that well, now she doesn't need inpatient admission, but her being able to exercise has been so important for her mental health, and she's actually doing a bit better. She still has a lot of challenges to manage, but really the point of this case study is to say that we as health professionals do not mean to do it, but sometimes we do have a nocebo effect, and we need to cause no harm first. So I mean, you know, it just happened to be that I was the right fit for this patient at the time, but it's just really important to know that, like, just looking at the real biopsychosocial factors for every patient and really thinking, like, is trying to hold up this mild cystocele and stop her from exercising the most important thing. Like, women are more than their mild prolapse or vaginas. So my take-home messages are that women should learn how to do their pelvic floor muscle training antenatally, and that there is good evidence that it prevents urinary incontinence, so send them if they can't do it, and they should learn to relax, contract and relax their pelvic floor muscles. Pelvic floor muscle training can also prevent, as I said, urinary incontinence postpartum, and there is evidence for pelvic floor muscle training for urinary incontinence for all women, and it can reduce symptoms of prolapse. As I said, the Perineal Care Clinic is available to all residents in the St George and Sutherland area, and that's not just for patients that delivered at the public. And please refer on for pelvic floor disorders in the antenatal and postnatal period, and also for advice regarding exercise, because sometimes we just don't know what they do. Sometimes I'm fascinated by what women get back to, and we work on what's achievable for them. In terms of contact details, like I said, I work privately and publicly, but just in terms of wherever you are, if you're looking for a physio, there you can look up the Australian Physio Association for pelvic health or women's health physio, and you can also look up the Continence Foundation. They also have a list of women's health physiotherapists. There's also the details for St George Public. There are also, I should say, there is no women's health physio at Sutherland Hospital in the public system. There are many in the private, but so all referrals from people in the Sutherland Shire go to St George Public. We are only 1.2 equivalent, and unfortunately our wait list is up to 6 months. We do triage. For like in terms of issues early postpartum, particularly voiding dysfunction, and also all OAC patients will be seen at 6 months postpartum. That is a separate perineal care clinic, as it's a multi-disc clinic with Dr Karantanis. In terms of other public hospitals, there is a women's health physio. There are women's health physios at Royal Women's, RPA, Canterbury, Liverpool, Campbelltown, Westmead, Nepean, North Shore, not at Bankstown, yes, and definitely not at Sutherland, unfortunately. Do you have any questions?
Hi, Edwina. Great. Thank you so much for your presentation. We have a number of questions that we'll try and get to all of them. We'll see how we go just with the time that we have left. So
Yeah.
someone's asked, so if pamphlets aren't very effective and patients can't afford a physio, what online resources would help, or videos? That's a great idea. You can look up the Continence Foundation. So there are online resources there, and there is a very good pregnancy handout which is all about the pelvic floor, which is given. It's by the Continence Foundation, and I know it's given to all patients in the antenatal clinic at St George and Sutherland, definitely. Yeah, and there are videos as well. I know that there's a video from, I think it's from the Continence Foundation, about how to contract and relax your pelvic floor.
And the other thing I briefly would say is sometimes I even just get patients to put their hand on their perineum and see if they can feel it contract and relax. Yeah.
Okay, great. Thank you. There's also another question. So many patients with traumatic births have not been told well beforehand that sometimes a natural birth doesn't go as planned, and if fetal heart rates drop, urgent forceps and/or an episiotomy may be needed. They're often shocked and disappointed, but why is this never taught in any natal classes? Why aren't they taught about the dangers if fetal distress is not quickly treated and intervention is often needed? It is hard to discuss this at the time.
I think that that's a really great question. I will say that I've taught the antenatal classes at St George and Sutherland for a number of years since 2014. I only stopped this year, but there is a physio session in those classes, and that is something I definitely discuss. So I think it should also be discussed with their midwives and like if they're seeing a private obstetrician, that kind of thing should be discussed. And that is a big topic at the moment in terms of what is informed consent and what does that look like for that individual woman. Yeah.
Perfect. Thank you.
I hope that answers it. That's a big topic. I could talk about that for a long time. Yeah.
I'm sure if there's a follow-on question, they'll pop it in the Q&A. We'll see if we'll get to it. There's also another one. So can you mention about women who present after pregnancies, even years later, who have fecal incontinence but minimal urinary incontinence? How does management differ? What else helps beside pelvic floor exercise if these are reviewed but not enough?
Because the evidence for fecal incontinence is for pelvic floor muscle training for fecal incontinence is not as good as it is for urinary incontinence. So we also work with the colorectal surgeons it's the colorectal nurse that does the anorectal physiology testing, so we know them quite well. But the biggest thing is, first of all, stool type. Make sure that the stool type is like firm enough, like a type 4, because if it's loose, that's often when they lose stool. Secondly, sometimes they use Imodium, like at PRN, or sometimes they'll use anal plugs. This is a quick run over. It is different. They need to be able to contract their anal sphincter and their puborectalis. It's very different to stress incontinence when they need to use their external urethral sphincter. So that's why we have to do a digital as well as a vaginal exam. Finally, if none of that works, SNM, sacral neuromodulation, can be very effective for fecal incontinence, and that's with a colorectal surgeon. So often with these tricky patients, we co-manage. Yeah.
Perfect. Yeah, I think there was just, another comment.
About the elective cesareans. Look,
yes.
I do not know why a woman who's had an elective cesarean would have fecal incontinence. I've certainly seen women with voiding dysfunction post-elective cesarean, and that's because it can affect the pelvic splanchnic nerve, I think, when the baby's coming out. And if it was a patient that had an emergency Caesar, I can understand if they were fully dilated that it actually affected the pudendal nerve, so that it caused some nerve damage causing fecal incontinence. But I can't answer that easily as to why they had an elective and fecal incontinence. There must have been other stuff going on. Sorry. Yeah. Without knowing more information. Yeah.
Great. No, that's fine. I've got another question. A non-perineal tear patient bought a TENS type machine from the women's physio that is inserted to exercise the weak pelvic floor muscle several years postpartum for both urine and stool incontinence. How effective are they and how do they work?
Okay, so that's a big topic. TENS for the OAB is incredibly effective, but we tend to put it on the ankle, right? TENS for if it's electrical stim for their pelvic floor, I barely ever use that for pelvic floor muscle training unless they honestly have zero muscle contraction. Women don't want to stick something up their vaginas to zap themselves. So I don't tend to use it. I'm probably more likely to use biofeedback in terms of there's a PeriFit, for example, or there's another brand, FemFit or something, where they put a probe inside their vagina so that they contract and relax. And that new one, the Fem something, it's very expensive, but it actually tells you if you're cheating. And so that's far more effective than trying to put something that stims your vagina unless you have no contraction. It's just like, for example, if you had like a biceps weakness, you're better off like using your biceps rather than trying to stim it with a TENS. Yeah.
Perfect. Thank you. I think there's just a comment here about lifting heavy weights in later pregnancy may cause abruption.
So absolutely, you know what? I am not at the end of the day the main caregiver. If there is a reason that patients cannot lift a certain weight, I wouldn't be recommending that. I'm just going on the general Canadian and Australian guidelines that it is okay to lift weights during pregnancy. Yeah, just to clarify.
Perfect. We might just have one last question. Edwina, would you be happy if I said
pick one?
the other? Well, yeah, if you'd like to pick one, but would we be able to get some answers from the other questions we don't get to today if I email them through?
Sure. Otherwise, I'm happy to stay at the end, and if there's any time I can answer. I'll quickly say that one about there's a question about collagen and EDS, hypermobile patients. That's a really big question, and I think I can't. I think that yes, there is a difference, right? That's what I'll say. They also tend to have pelvic pain, and that's a really big topic about hypermobility. Having said that, that patient that I mentioned who had prolapse, stage 1 prolapse, she had EDS. And I certainly don't think that just because she had EDS that she should not then, she actually told me that lifting helped her hypermobility. So that's why for that vulnerable patient, I thought that let's go with what she needed to do. But yes, I think I'm over time. So the other questions I can try and answer on email, or I can try and answer them at the end. Thanks.
Okay, great. Thank you so much, Edwina, for your amazing presentation. We'll head into our second presentation for tonight. So I'd like to introduce Dr. Hester Wilson, who's a GP and medical advisor for CESLED, Population and Community Health. Dr. Wilson will be presenting on weight management in pregnancy. Thanks for joining us.
Hi, let me just see if I can share that screen. Okay, can I just check? Are you seeing the correct screen?
Yes, all good. Thank you.
Fantastic. All right, thank you so much. So I've been asked to come and have a chat to you guys tonight about weight and pregnancy. And just looking at this particular picture, it's really looking at all the important things in terms of assisting our patients to have the best possible pregnancy they can have. Healthy eating, good obstetrics care, good midwife care, emotional, psychological health, social wellbeing, exercise, all those things that are really important in terms of having a good good pregnancy and healthiest baby and best outcomes that you can. Now, let me see. Okay, I do just want to make an acknowledgement of country, and this is a photograph of Aboriginal high protein, low carb foods that is certainly very important for our Indigenous peoples in terms of their diet, and we've seen the incredible shift that has happened in that diet and the impact that's had for the well-being of Indigenous peoples in Australia. But I'd just like to acknowledge the traditional owners of the land on which I am, the Gadigal people of the Eora Nation, and pay respects to past and present elders and emerging elders and anybody Aboriginal who's with us here tonight. The learning outcomes, going to be talking to you for about half an hour and then time for questions. Really what we're going to be looking at is ways that we can minimise the risks and challenges of weight gain in pregnancy, and work out how to best assist patients with managing their weight during pregnancy and reducing the patient's risk of the related complications. Now, for this talk, I have really focused on the issue of working with women who are above healthy weight range. Okay, so next one. Just want to flag checking weight, and I'm sure that everybody is aware of it. I really do like this BMI calculator from the Australian Institute of Health and Welfare. It's a really nice one where you can put in the weight and the height, and it gives you this graph, which gives you a sense, and you can do it with your patient to just give a bit of a sense of where they're sitting in the graph. I will talk a little bit about language, but I think this is a really nice one One of the things that sometimes I see with some of my patients is they're very, very worried about weight, but they're in the healthy weight range. And we do have in our community these unrealistic ideas of what weight is. Sometimes people will underestimate what healthy weight is. So it's a nice one, and I'm very happy for you guys to have these slides, but just look it up. It's quite a useful one. The other thing that is really important is that people who are above healthy weight range, who are overweight or obese, experience massive stigma. Now, they're not the only group in our community that experience stigma, but it has real impact. The stigma that people experience impacts their ability to come into treatment, to stay in treatment, and the outcomes from treatment are not as good. It also increases their risk of mental health issues as well. It creates an internalized stigma, an internal sense of shame that is pernicious and difficult and contributes to the ill health. It's worse for women than for men. I have to say that we live in an obesogenic society. It is this whole kind of thing that we have at the moment, which focuses on individual responsibility and exerting willpower, is all very well. But we do live in an environment where we don't move as much as we should. We have easy access to low quality, low value, high carb, high salt, high sugar foods. The idea that the individual is solely responsible for their weight is sadly not true, and really flag the importance of regulation and legislation, town planning, societal-wide changes that actually help us as a community to keep in healthy weight. At the moment, 2 out of 3 adults in Australia are above healthy weight, and 1 in 4 children. The other thing is, and this is just a reminder to me, check what else might be going on, is to think about what might be some of the causes that might be leading to this person being above healthy weight. So of course, looking at other health issues that might be contributing to that, but really looking at where are they living, what are they doing, what are the circumstances in which they're living their lives that are going to have an impact here. In terms of assisting people to maintain healthy weight or to change weight, we really want to focus on well-being and healthy behaviours. Really think about those other things, the stress that they may be feeling, and the impact that has on weight and people's sleep patterns. Really, really important to be looking at it more holistically than just a simple thing around weight. There's quite a lot of literature. Once again, this is looking at, comes out of the stigma work and some work that was done in Australia not that long ago with rural Australian adults, so men and women, and it was more of an issue for women, but really important in terms of the language that we use. So I'm going to be talking to you about overweight and obesity. They're medically precise terms. We don't use the word morbid obesity, but I mean, it's those aren't medical terms, and we do use them to be precise. But what we find is that those terms feel stigmatizing to people. The classic one was one of my colleagues who is a specialist in childhood obesity, having parents come to her and say, "They told me that my son was a beast. He was a beast." And what that means for people. And really, when we're looking at this to assist people who are above healthy weight range, who are overweight or obese, is talking about it as above healthy weight range, that focus on health. Your weight may be damaging to your health. Your weight may be damaging to your baby's health. Importantly, though, people do find it acceptable to have their weight measured by their GP and to have conversations around this. They see it as part of our role. Just looking at some of the inappropriate language, and this on the right here with the inappropriate language, this is a particular summary which comes out of some work done with Indigenous Australians. But words like overweight, obese, fat, chubby, need to lose weight, try to lose weight. You know, and I have to say, as a doctor, I've talked about overweight and obesity. I've talked about fat and chubby. Need to lose weight, try to lose weight. It's not language that is particularly helpful. So really that focus on becoming fitter, becoming healthier, becoming stronger, and being above healthy weight range, or a BMI that is above the healthy weight range, are the ways that people find more acceptable and easier. And so really think about the language that you use, because it may seem like I'm making a lot out of something that's not important. It actually does. And weight stigma, it is a huge issue. And it's really important for us to think about it. So just once again, if we're looking a little more specifically at women and the weight of women in childbearing years, and this is in a couple of years ago in New South Wales. So a very small percentage were underweight, just over 50% were in the healthy weight range, more than a quarter were overweight, and nearly 20% were obese. And I'll talk to you about what those definitions are. If you lived in social economic disadvantage, it was worse. So more people were above healthy weight range, and much higher levels of obesity. The other thing that we find is that there are increased issues with weight as women have more babies. So more than 3 pregnancies, the rate of obesity is at more than a third. 4 or more pregnancies, it's almost half. So really important to consider the group of women that you're working with. The other thing, and this is my little thing here on the side, you don't have to lose very much weight for it to have incredible benefits in your health. So once again, it doesn't. If somebody is above healthy weight range, even changing that and bringing that weight down towards the healthier weight range is going to have massive benefits. So it doesn't have to be all or nothing. The other thing is, in pregnancy, the more of an issue you have, and if you're obese, and we have three types of obesity, 1, 2, and 3. As people become more, their BMI is higher and higher. There is increased rate of a number of health conditions, not gestational diabetes, particularly hypertension, increased risk of preeclampsia, increased risk of having a cesarean section, postpartum hemorrhage, stillbirth, premature birth, congenital abnormalities, including spina bifida, big babies because they're of the gestational diabetes and the amount of carbohydrates. Increased risk of wound infections and thromboembolism. Look, and increased risk for the baby of ischemic heart disease, above healthy weight range, and diabetes. This is all made worse with smoking. Obstructive sleep apnea, and interestingly in this group, lower rates of successful breastfeeding. When we're thinking about when we might have this conversation, we as GPs are really fortunate that we see people over time, and we see the vast majority of our community, and we commonly see young women and women of childbearing years. So really having that conversation opportunistically when you see people, to look at whether they are in healthy weight, and consider polycystic ovaries. We know now that polycystic ovaries is quite a complex condition, and quite often there's a long delay to diagnosis, and it is an important condition to diagnose and manage, because it increases fertility if you can manage that, and decreases your risk of cardiovascular disease as well. Along with this is the opportunity to talk about alcohol use, tobacco, other drugs, and talk about them at every opportunity. So when you're seeing a woman, in childbearing years, really starting to have those conversations. And, you know, it might be that they're coming in for their contraceptive pill or they've had a cold or whatever. But really looking for those opportunities to send those preventative health messages. Because ideally, you want to be in the healthy weight range when you fall pregnant. It makes it really decreases the risk of the pregnancy if you are within healthy weight range. The other thing is that more that people are outside the healthy weight range, the more support they will need. And it is one of the things I think that's sometimes tricky with stigmatized conditions is the more that people actually have the condition, the more severe it is, the more difficult it is for them to access services, the more difficult it is for them to stay in treatment. And it is really important that we are putting together a package and supporting them as much as they need. So I just want to start with a case study. So this is Julie, age 23, and she is not pregnant currently, has not had any previous pregnancies, and she's attending a surgery for contraceptive advice. She's been using condoms and now has a regular partner. And she's just looking for other options to manage her contraception. So the condoms worked well, but they're planning to stop using the condom, and so she's looking for the pill. What else might I use? She's got no medications, there's no chronic conditions, and as a part of the routine lifestyle assessment that you take the opportunity to do because you're her GP and you're concerned for her well-being, you ask her about her lifestyle, including her drinks and her alcohol. And she says, I have 4 pre-mixed drinks both Friday and Saturdays, and I've actually cut this down recently. She's an ex-smoker. And has no other drug use. I would flag at this moment that I would be taking this opportunity for her as an ex-smoker to say, congratulations, that's really great that you're an ex-smoker. Is there anybody in your house that smokes? Is there any, and just thinking about how you might be able to spread that message around the fabulous work that she's done giving up and supporting her to stay as an ex-smoker. The other thing is also congratulating her on cutting her drinks down. Her height is 165 centimetres and her weight is 87 kilograms. So then we can see from our graph that she has a BMI of 32, so she's within that orange level, which is class 1 obesity with a BMI between 30 and 35, so well above healthy weight range. So I'm not sure that we can do this, sorry. Go back to the previous, because I can't see anything else on my screen. I can't actually see the chat. I was hoping that I might get you guys to give me some feedback in the Q&A, but I don't think we're going to be able to do that. So, and so really for me, it's go back, giving my answers away. The issue here is that we have a young woman that's coming in for contraceptive advice. She is sexually active. She may not be thinking at the moment about having kids, but it's not a bad time to be actually just putting those preventative messages in. As I said before, congratulate her on not smoking. Congratulate her on cutting down alcohol. Respectfully asking her about her weight. We've done the measurements. That gives you a BMI of 32, which is well above the healthy weight range. I'm wondering if that's something you're concerned about. We do know that having a weight above the healthy weight range does increase the risks of health issues. Is it something you'd like to talk about some more? And are you planning on having kids at some stage? The important thing here is that ideally, it's good to be in the healthy weight range when you fall pregnant. You're more likely to be able to fall pregnant, and you're not going to have those risks during pregnancy if you stay within the healthy weight range. So this is an opportunity for us to have that conversation and support her, offer her treatment for her current weight so that she can actually get it back to the healthy weight range. The other thing is to just, once again, I'm just thinking if we're talking about planning pregnancy, Just flagging some folic acid and iodine at least a month before. We do know that the vast majority, it's about 50%. I can't remember the figure. Sorry, I've lost it. But it's very common for women to have unplanned pregnancies. The other thing here, while we're just talking about alcohol, is that it is that the current guidelines have been strengthened around alcohol in pregnancy, and the advice is to not drink in pregnancy. So this is an opportunity. Oh God, sorry. Don't know how that happened. This is an opportunity to just mention that it's best not to have any alcohol during pregnancy at all, and if she's thinking about falling pregnant, or if there's a risk of falling pregnant, it encourage her not to drink at all, rather than those Friday, Saturday nights. And now we come to Marley, who attends your practice. She has a positive pregnancy test and is seeking pregnancy care. This wasn't a planned pregnancy, but she's very happy. Now, she has a BMI of 30.9. So once again, she's above healthy weight range in obese class 1. She has a South Asian background, and her mother has non-insulin dependent diabetes and had gestational diabetes in pregnancy, and has some issues with her sight, her kidneys, and her heart. She lives with her male partner and his 10-year-old son. No medications. Once again, as part of your routine lifestyle assessment, you find out she stopped drinking as soon as she found out she was pregnant. I would be really focusing on that being good news. Congratulations. It's great that you stopped drinking as soon as you found out you were pregnant, and you're an ex-smoker. That is wonderful. Once again, is your partner or is anybody smoking in the house, preparing for, trying to have a smoke-free home. So her date of delivery is going to be next year, if we're looking at it from today's date. So she's early in her pregnancy, but she does have a BMI of 30.9. So there are some issues for Marley, and we know with this weight that she is at increased risk, and we would really like to support her to have the best possible pregnancy outcomes that she can. So what is normal weight gain in pregnancy? So one of the things, when you're pregnant, it is not a good idea to restrict and try and lose weight. What you want to do, if somebody is above healthy weight range, is to just moderate the amount that they gain. So if you are low weight and under the healthy weight range, put on more weight. If you're within the healthy weight range, it's from 11 to 16 kilos. If you're overweight with a BMI between 25 to almost 30, 11 kilos, and a BMI of 30 and over is up to 9 kilos. If you've got a multiple pregnancy, of course, there will be additional weight gain. So I've got another graph here, which is taken from the Royal Hospital of Women in Victoria. And the thing that is interesting here is that they've looked at some genetic and racial group differences. So in someone who is Asian, what they're saying is that the levels of healthy weight are different. So for Marley, who has that South Asian background, she really is sitting in that that higher risk. I mean, she's from our general one, there's BMI of 30.2, but here it's actually she's at a higher risk. An average gain in the first 3 months go for up to 2 kilos, but then really just try and slow it down if you are above healthy weight range. The other thing with checking this as part of our assessments is that keep doing it as a part of it. I mean, we do, but keep checking the BMI. As I said before, be aware of cultural background, be aware of the impact that has. Any other health issues? Has the woman had previous bariatric surgery? People may not disclose this, particularly if it hasn't been successful, but either way, if somebody has had bariatric surgery in the past, they may well be deficient because of that surgery in some of their macronutrients and vitamins. And so additional supplementation, and in pregnancy this is particularly important. The other thing is serial ultrasounds to assess fetal growth. Now, I would flag I am not an obstetrician, and from my point of view, if somebody is well above the healthy weight range, it's really good it's a really good idea for them to be seen in the high risk pregnancy clinic, and to be doing that under the care of the obstetrics team. Some really nice information out there for pregnant women around eating in pregnancy and nutrition in pregnancy. There used to be that old adage of eat for you, you're eating for two. It's not in fact the case. But you do need to put on weight, and you're supposed to put on weight. But really looking at vegetables, lean protein, and whole grains, which is ideally what we should all be eating. But really, once again, it's making sure that you've got those good quality, lean protein, whole grains, nutrients from the fruit and veg that actually help you to actually make sure that you've got all the nutrients that you need, and thinking about the ways you can swap out some of those sometimes foods. So that is, whatever your BMI is, that's the way to go in pregnancy. And exercise 30 to 60 minutes, moderate a day. And once again, really important. You don't want to do contact sports. That is an issue. But you can continue doing the exercise. Your patients can continue doing the exercise that they enjoy, and they don't have to give it up. Once again, if there are issues in terms of other health issues, of course, but it is absolutely fine to continue doing that exercise. Folic acid. And once again, those 5 milligrams daily, a much higher dose of folic acid if they have a BMI over 30. Iron when needed, calcium when needed. Iodine, caffeine, as we normally would do, the 1 to 2 cups of coffee or the 4 cups of tea, does depend on how strong your coffee is. Once again, with the previous bariatric surgery, really do be aware of that. Offer early diabetes screening. And early delivery is offered with women with a BMI of over 50. In general, don't forget your COVID and influenza vax that are so important in pregnancy. And basically what I'll say to women is, increase what you eat a little. You don't have to eat for two, just increase it a little. And looking at the plate, and I really like this, your half plate of veggies, salad and fruit, your quarter plate of protein, and your quarter plate of carbohydrates, and going for those whole grain carbohydrates as well. So coming back to Marley, so she's got a delivery date in April, so we've got plenty of time. I wouldn't be saying to her, lose weight. Don't try and lose weight. However, we do want to limit your weight gain. We want you to have good doses of folic acid and iodine, and let's do some early screening, particularly with that family history. You'd be wanting to do that anyway, but in someone who has a BMI of over 30. Give her the COVID and influenza vax. Talk about those healthy food choices. No fasting. Don't take on the 5-2 diet or anything like that. And ideally, I think it's a really good idea, if your patient can afford it, to see a dietitian to just get some advice around how they do that. Quite often for women that are above healthy weight range, they may not be exercising very much. So we don't want them to go, right, I'm going to go and start doing marathons. No, build it slowly up, build it gently up to increase that exercise. As I said, with people who have a BMI of over 30, referring for antenatal care, referring to those high-risk pregnancy clinics, but we as GPs have an important ongoing role. People with above healthy weight range BMI, this is a chronic illness. It's not something that they deal with once. It is really a long-term process, and it's around healthy diet, healthy exercise, and maintaining that. And so we have a really important role in following up our patients who have this experience to help them to gently bring that weight down, to come back into that healthier weight range, and to maintain it over time. And that never stops. So as I said before, if a pregnant woman is already above healthy weight range, already obese or overweight, don't aim to lose weight. Aim to slowly gain weight. Get that extra support, because doing this is hard. You know, it is around changing lifestyle. It is around changing diet. And one of the important things that we know is that these changes are really well done if they're done family-wide. So, for example, with the patient Marley, she's got the 10-year-old, her partner's 10-year-old son and her partner. Once again, I would be interested to understand where the partner and the son are sitting in terms of their BMI. You have an opportunity to intervene in this family, and if they are also above healthy weight range, to work with them as a family with such a benefit to their health and well-being. As I said before, don't forget to follow up and support. It's a lifelong condition. I went and had a look at South East Sydney Health Pathways to look at weight management in pregnancy. There's not really much there. There are some pathways which are around being above healthy weight range. And South East Sydney Local Health District just suggests in pregnancy see a dietitian. It is a little tricky for people to always be able to access this because of cost. If but there are different services available. Check them out in your local area. The one thing that I did want to flag, and it's a really great service, is Get Healthy. Now, I don't know if any of you are aware of Get Healthy. It's a free online phone service, coaching service, health coaching service. And there are different divisions of it. So we have Get Healthy in Pregnancy. And so focusing on this one for this talk, it's free. And what you do is you can refer or you can get your patient to self-refer. For example, with Marley and her family, she can go along, her partner can go along and do his coaching as well. The 10-year-old Get Healthy is only for 16 and above. But once again, that approach of if Marley and her partner are both above healthy weight range and they change how they eat, they change their exercise, that's going to have impact for the 10-year-old if the 10-year-old is also above healthy weight range. So it is tailored to your needs. So in terms of Get Healthy in Pregnancy, women can take part in that, and it's a 6-month coaching course. And it may be that it's around better nutrition. It may be that it's around building up physical exercise. It may be that it's around bringing the BMI down. So these are health coaches, dietitians, exercise physiologists that help you to set and achieve your goals. The other thing, of course, in pregnancy is that support around alcohol. So Get Healthy has, as I said, a number of different groups. So there's Indigenous, there's cancer care, there's the general adults over the age of 16, there's Get Healthy in Pregnancy. And there's also the options for a number of different languages as well. So there certainly is the Chinese languages, Greek, Arabic, number of different languages that you can get the coaching in as well. So this for me, Get Healthy is such a good news story. Certainly in South East Sydney, not many of us are actually referring to this service, and it is a really good service. I decided if I was going to be someone who promoted this service that I really needed to understand what the service was. So I enrolled in Get Healthy. I didn't tell them that I was checking them out. I just went along and did it. And so I went through the program over a 6-month period with the health coaches. My focus was around my physical activity, and it was terrific. Every 2-3 weeks, 4 weeks, depending on what we sorted out, was someone talking to me, helping me to set my goals, coming up with some good solutions. It was really very, very useful. I would flag for someone that has a very high weight, healthy weight, is very much above the healthy weight range, that Get Healthy is probably not going to be enough, but it is part of the picture. And part of the supports that they can put together. And certainly I have to say that the Get Healthy in Pregnancy is really, really fantastic. The feedback that I've had from women that have taken part in the program has been very, very positive. Okay, so that's it for me.
Thank you so much, Dr. Wilson. Such a great presentation. We have a few questions for you. Some of them are pregnancy related, some are just in general. So I will just start with the first one, asking about, they were just mentioning about the stigma around and saying obviously prevention is the most important. Can GPs use Ozempic if not pregnant? Does that help? And then they're asking about VLCDs.
Yeah, so the VLCDs, the very low carbohydrate diets, not in pregnancy. You wouldn't want to use them in pregnancy. You don't want to have highly restrictive diets in pregnancy. What you're looking at in pregnancy is if you have someone that's above healthy weight range, they still will put on some weight. So the other thing that I probably should have covered is the importance of how you support women after pregnancy. Breastfeeding is really fabulous for helping women return to healthy weight. So don't underestimate that. And one of the issues that we find it is less common for women who are above healthy weight range, particularly if they're with a BMI greater than 30, to actually breastfeed. I don't think that's actually anything to do with being with their weight, but perhaps there aren't the supports around them to help them successfully breastfeed. So a real focus on getting breastfeeding happening, because it's so good. And I don't know, with my kids I breastfed, it was fantastic and it's so easy. But you don't want to be using, you don't want to be losing weight in pregnancy. In terms of Ozempic, look, it is not licensed for it is a weight loss medication, absolutely, but it is on the PBS for type 2 diabetes, so it is a private script. One of the issues that we have at the moment with Ozempic is that it's in short supply. You can absolutely prescribe it as a private prescription. It's around about $130 a month for the injection. There is a new one that's going to be coming out that is a higher dose, and that has greater efficacy with weight loss. There's no doubt that it is a very helpful medication. The issue that we have is that it has a few side effects and can make people feel quite unwell and they just don't want to eat. There's no doubt that it does help people lose weight. One of the tricky things is how long people continue on it, and as soon as you stop it, there are a group of people who continue, and they do really brilliantly. Another group of people where the weight goes right back on. I think there's a lot more to the story with these medications that will become clear over time. But there are concerns around the use of Ozempic in the wealthy Warwick well that don't really need to lose weight, so I would really be looking at people that actually have diabetes, people that have significant mental health issues, and who are very much above the healthy weight range, rather than people who it'd be nice if they could lose a couple of kilos, and they absolutely can do that quite easily, just because what else is there? Doesn't help. Yeah, but we wouldn't use this in pregnancy. You wouldn't take the medication in pregnancy.
Perfect.
Yeah.
Thank you. And I think that there was another question about the Ozempic as well. in terms of better results for weight loss for obese patients. And I guess they're asking, should they be using these or referring for gastric bands or Jenny Craig or dietitians? And then asking about metformin.
Yeah. Look, metformin certainly has a place. So as do dietitians. I mean, I think there is not one right answer. Certainly we do need to be supporting our patients to have healthy, regular exercise, and to be eating a healthy diet, which is lean protein, whole grains, and lots of fruit and veggies. In terms of gastric banding, look, the bariatric surgery, it certainly does have a place. However, what we are seeing is with Ozempic and the new medication when it comes through, Vegova, I think it's called, that the rates of surgery are going down. Surgery is expensive. And it can be quite successful, but one of the things that we quite often see is that people keep that weight off for a couple of years, but then they start to put the weight back on. And so the gastric sleeve or the gastric banding, the bariatric surgeries do have a place, but I suspect we're seeing it already. Many people not needing it because they're able to lose weight. It's not just the medication, though. It's actually a very broad change. And as I said before, it's really important to be doing that in families. You really want to have a whole family approach so that the diet changes, the nutrition changes within the family, and they're looking for, as a family, ways that they can actually increase their exercise together, ideally.
Okay, great. Awesome. And anything about metformin?
Metformin, especially for people on drugs that increase appetite as well as other people. I mean, metformin really has a place in diabetes. And once again, I wouldn't be using it in pregnancy. Yeah.
Sorry, I'm just looking at, there's a few questions now that have come through. There was one about the good brand of iodine.
I'm sorry, guys, I don't know. I'm not an iodine expert. I have to say, I leave that to my patients to do that with a pharmacist. I'd be getting a pharmacist to help me out with that one.
Okay, great. And I think there was just another one asking, people ask why you gain more weight as you get older, not just after pregnancies. Does the metabolic rate slow down until you get to about 80 or 90?
Yeah. Look, I think that, and certainly what we find is that as people get older, their weight goes on, and really core to that is the way that people's lifestyle changes. And the way that our lifestyle has changed, so, as a young person, and this is a really common thing with blokes, they used to be playing rugby, they used to be running around. Now they're sitting in front of a computer screen. And we have this, fast food industry and look, and that's the other thing that's really important in terms of being above healthy weight range. Really commonly, people are nutritionally deficient. They're not getting the micronutrients, they're not getting the vitamins and minerals and the nutrients that they need. And it's a lifestyle thing that's really important. Looking at mental health, looking at the amount that people drink with the empty calories or kilojoules that you get with drinking as well. So really starting to look at how do we maintain that. As people get older, of course, then there could be things that get in the way of them being able to exercise. For example, their osteoarthritis. So looking for ways to manage that chronic pain, but it's still the weight-bearing exercise that's going to help keep them strong. But also it might be doing things like swimming and gentler exercise. We certainly do see a change in metabolic rate. We definitely see a change when women go through menopause. That does change. And people will really commonly say, I used to be able to get away with eating anything, now I can't. But it really is looking at that as and for us, we're working at an individual level. And that is really important, and that's our role. But I really want to flag that we can't do it all at an individual level. And we live in this obesogenic society where we don't move and we eat a large amount of low quality, high energy foods. sugar tax. I know we can't really shouldn't call it a tax. Let's call it a levy. But we do not need to be drinking sugar drinks. We just don't need them at all. We really don't. We should be just drinking water. So but they're everywhere. So there are real issues around us as a society and how we need to do that differently. Anyway, I'll leave that because I could talk about that for ages, but it's not what we're here for.
That's good. I just thought I'd mention, because we obviously won't have time to do the health pathways presentation. So Dr. Gerges has just asked to refer, which I will be sending out some health pathways slides post-event, just on the weight gain in pregnancy under the antenatal care routine page. And then obviously the Get Healthy in Pregnancy and the referral details. So we'll be sending them out afterwards.
Yep.
I just thought, Dr. Wilson, are you still in the questions? Is there anything else we should touch on? I'm just mindful it's 8:59.
Yeah.
And I think we've got Edwina's
There's
got
a
her hand
lot-
up as well, so I'm not sure.
Yeah, look, there's a lot there about the medications. Look, bottom line is they do have a place. It's kind of outside this talk though, really. I think that's probably it. Yep. So look, and there are dietitians in different places. So St George absolutely has a really good dietetics department, but it's not the same across the whole of Southeast Sydney and sorry, you guys are also Central Sydney, aren't you? As in Sydney Local Health District. So look for what is available in your area. The other thing is that there is a private program that's running in Miranda that does have some charges, but they do some really good work in this space at the Integrated Specialist Care Centre there.